Hello guys, welcome to our channel. Today we will be discussing the pediatrics rapid revision, and in this we are going to discuss again same all important topics and the most important topics you have to do before the examination. So those who want to take the notes, you can text me in the telegram from the group. After joining the group, you can text from me there. And those who are new to this channel, please do subscribe and share with your friends. So let's start the discussion, guys. So as we are discussing every day one great scientist contribution, so today we will be discussing about the Dr. Kawasaki. His name itself, Tomisaku Kawasaki. So this great doctor, he is actually a nurse. After the completing his nursing, he has done the medicine and also he has done the pediatrics. So during the pediatrics research, he has found some peculiar symptoms of the patients like fever and unusual heart symptoms. So he found out this is the Kawasaki disease which will be affecting in the children coronary arteries. So his contributions have saved us millions of the people with the Kawasaki disease with the early management. Still, it is a highly expensive management, but still some of the patients have got the decreased mortality rate with this with his contributions. So let's start the discussion, guys. So first and foremost important thing, that is the APGAR score, right? APGAR score is one of the most important APGAR score that is done for the every neonate that is born, every newborn born. We are going to do the APGAR score, right? What is the APGAR score? It is given as a 0 points, 1 point, and 2 points. So the more the score, more the healthy the children is. So A for appearances, 0 point is given for the cyanotic and the pale, and peripheral cyanosis only, then the 1 point, and complete body is pink color, then it is 2 points. Pulse, if it is no pulse at all, that is 0. If it is less than 100, 1 point. If it is more than 100, that is 2 points. Grimace, grimace is nothing but irritability. We are just irritating the baby. And no response, that is a 0 points. Some grimace, some flexion is seen, that is a 1 point. And cry whenever you are stimulating or the irritating the baby, that is the 2 points. Activity, it is about the tone. So if it is a floppy baby, that means complete hypotonia, that is a 0, and some flexion is 1 point, and well flexed is the 2 points. Next, respiration is completely apneic, that means no response at all, and slow irregular, that is a 1 point, and strong cry, that is a 2 points. So that's why whenever any people in the MBBS, whoever preparing, they will be telling, oh no, I don't want to take the pediatrics because the children will cry. But remember the one fact, if the children is crying, that is the normal function. If the children is not crying, that is the abnormality. So crying children is good, healthy babies. That is the first thing that you have to remember in the pediatric classifications, right? This is the one point. Next, how many times we are going to do this APGAR score? At 1 minute, followed by the 5 minutes, and followed by the 10 minutes. So this is how the pattern we are going to do. And if ever the score is 7, then likely to be the patient is having the pathology, especially with pathology, guys, the pathology which will be related to the neurological conditions. One of the examples is the ischemic, the intraventricular hemorrhage, like hypoxic ischemic encephalopathy. These are the conditions that can be seen in these patients. Next, we also have the other two important scores. Okay, we also have the other two important score. One is the Downey score. One is the Downey score. Downey score is done for the again respiratory distress, especially in the term infants. Okay, especially in the term infants. So here also the scoring will be 0, 1, 2. But in these patients, the more the score, more the severe. Here, the more the score, more normal. But here, the more the score, more severe condition it is. So what we are going to check? We are going to check the respiratory rate. Okay, remember this is about the respiratory rate. So this is 40 to 60 per minute, and the 1 point is given for the more than 60 per minute, and then 2 points is given for the more than 80 per minute. Okay, this is how we are going to classify the respiratory rate. Here we are checking only respiration. Here we are checking for the respiratory rate. Next, cyanosis. Right, if the respiration is disturbed, obviously the patient will be having the cyanosis. And the baby, if is no cyanosis, that is normal 0 point. And there is a cyanosis that you are seeing on room temperature, sorry, on the room air. If you see, that is 1 point. And if you see, even if we have increased 40% of oxygen, still if you see the cyanosis, then that is a 2 point. Okay, next, air entry. So is the air is entering properly or not? If air is entering, you can see that is normal, and it is completely decreased, that is a 2, and marked decrease. You cannot even hear with your stethoscope also the air entry. That is the 2 points. Next, retraction. It could be intercostal, or it could be the grunting, anything that you are seeing with the retractions. There is no retraction, that means normal, and minimal retraction is 1 point, and severe retractions is marked, that is a 2 points. Next, grunting. Okay, in the grunting, there is no grunting, that is normal, and it is heard with the help of the stethoscope. Then it is heard with the help of hearing. Okay, with the your naked ears, if you hear, that is a 2 points. If you just heard by the stethoscope, that is a 1 point, right? Next, Silverman score. And Silverman score is mainly about the preterms, those who are suffering from the respiratory distress, hypoxic ischemic encephalopathy. All this we will be seeing in this Silverman Anderson score. And this is also seen 0, 1, 2. Okay, 0, 1, 2. Mostly it will be retractions. Okay, no, no, there will be nothing about the respiratory rate and everything. You just have to remember respiratory rate and grunting. Okay, so same again, same. If the retractions is not seen and severe, it is going to be the moderate. Let's say this is the mild, moderate, and severe retractions. Okay, and next, here in the grunting, it is heard just minimal, and here it is also heard about with the help of the stethoscope. And the two, it will be audible with ears, audible with ears. So this is the Silverman Anderson score, right? This is how you can just remember these important points of the Silverman Anderson score, right? Next, moving on to the some of the important reflexes. So whenever we saw the reflexes, you all have to remember the one is the Moro reflex, because Moro reflex has a two different phases. What is that? So that is the phase one. Okay, in the phase one, the patients, whenever you are acting with this baby, not the patient's baby. So first one will be the abduction, followed by the extension, and immediately within seconds they will enter the phase 2. What happens in the phase 2? Adduction. They will come nearer and then flexion. Okay, some babies will cry in the end. So this is what the normal of the phase 1 and the phase 2. So first abduction, extension, third abduction, adduction, and the fourth is a flexion, and followed by the cry, sometimes is there or not there. Why it is important? Because this will tell us that the baby's CNS function is intact. This is the first thing. And next, where it will be present? It will be present by birth. By birth, everyone, even one of us also going to be, everyone is going to have this at birth. And when it is going to disappear, it is going to disappear by 4 to 6 months of life. It is going to disappear. This is going to disappear. Next, where it is absent, complete absence of the Moro reflex is seen in the hypoxia patients, hypoxic ischemia, and also prematurity. Prematurity patients also, it is going to be decreased. And sometimes it is unilateral or abnormal Moro reflex is seen in the Erb's palsy. Okay, here you are going to see the abnormal Moro reflex is being seen in the phase 2. Okay, next, coming on to the jaundice, different types of the jaundice that we have to discuss. First one is the physiological jaundice. First one is the physiological jaundice. In the physiological jaundice, this jaundice is occurred after 24 hours of life. After 24 hours of life, you are going to see. And how this is going to be presented? Mostly, this will be presented as a unconjugated type. Unconjugated type, if we see, it is most commonly Rh positive or ABO blood grouping is the cause. This is the cause that you are going to see, and usually it is going to complete in the 2 weeks only. Within the 2 weeks, there will be cured. And themselves only, they are going to just with the supportive treatment, it is going to close, right? Next, pathological type. In the pathological type, what happens? During the pathological, it will be less than 24 hours. Less than 24 hours of life. Followed by, there will be conjugated bilirubin. Okay, there will be conjugated bilirubin, that is here, and most of the times the cause will be biliary atresia. Okay, extra biliary atresia will be seen in this patient, and it can be 5 mg more than to 15 mg. If it is crossed 15 mg, it can connect with the CNS also. That is a very risk for the patients if it is involving the CNS. Why? So here the condition, this is the kernicterus. This is the kernicterus. What happens in the kernicterus? That basal ganglia, sorry, the basal ganglia is involved due to abnormal bilirubin levels. Abnormal bilirubin levels has been damaged this basal ganglia. So patients will be initially having the hypotonia, and immediately they will be converted into this hypermotor activity. So this position is spasticity. Okay, spasticity is seen in the basal ganglia damage that you are going to see. Next, we have the breastfeeding type of the jaundice. Breastfeeding of the type of the jaundice, that the mother is breastfeeding is less. Okay, what can you do? We can just continue the breastfeeding. Next, breast milk type. In the breast milk type, the glucuronidase is absent. So that's why the patient is having the breast milk jaundice. And this is most late presentation, and you can do simply continue breastfeeding. So how can you treat this condition? So the treatment is basically whenever you see the severe jaundice, if it is involved, the treatment of the jaundice will be phototherapy, right? Phototherapy. If there is a not going, for example, pathological jaundice, let's say it will take 2 to 4 weeks to recover. So for these patients, we can go for the phototherapy. What does the phototherapy is doing? It is going to use the 460 nanometers of the light, and it will change the bilirubin to the lumirubin. Okay, bilirubin is going to converted as a lumirubin so that it will be excreted from the body. So this is known as a structural isomerism. Okay, this question has been also asked. Structural isomerization is seen in the phototherapy treatment. So the last choice can be, it could be structural isomerism. If it is not work, what we can do, we can go for the patients, those who are with this condition, we can go for the exchange therapy. Exchanging of the plasma can be also done. Next question, next condition. Next condition, that is necrotizing enterocolitis. Okay, necrotizing enterocolitis. What is this necrotizing enterocolitis? Basically, this is associated with the prematurity. Whoever born less than 34 weeks or the 37 weeks, there will be high risk, and also formula feeds. Okay, and also formula feeds. This necrotizing enterocolitis will be seen. And what happening here? There is a bacterial growth. Okay, there is a bacterial growth which causes the inflammation. Abnormal inflammation is seen. Why this bacterial growth is seen? Due to necrosis. Okay, due to necrosis is caused. Why the necrosis is caused? Due to ischemia. So the name itself telling that necrotizing enterocolitis. So once the ischemia is triggered, it going to cause the necrosis, and vice versa. Bacteria will increase and normal tissue die again. So it will be spreading to the surrounding structures also. This is the necrotizing enterocolitis. We have the special staging that is known as a Wells staging. The staging is Wells staging. Here you can see this is the stage 1, where you are going to see abdominal distension and also bloody stools can be seen. Next, this is the stage 2. This is the pneumocystis intestinalis. So this is the intestine and this is the layer. So what happening? There is a air in between this intestinal layers. That is a pneumocystis intestinalis. Next, this is if it is stage 4, there will be perforation. Okay, stage 4, there will be perforation. Stage 3, it is peritonitis. Stage 3 it is peritonitis. So this is how the patient will be having. Sorry, there is no stage 4 guys, don't confuse here. This is stage 3A peritonitis, stage 3B that is the perforation. And how we are going to treat these patients. So whoever is suffering from this condition, necrotizing enterocolitis, what we can do is, so stage 1 and 2 and 3A, we can go for the supportive therapy. So supportive therapy, mostly we are going to keep the patient on the nothing per oral, then IV fluids. But stage 3B, already is the stage 3B, what happens? The stage 3B, the patient will be having the severe condition, right? So we have to do the surgery. Surgery has to be done for this patient. Open laparotomy should be done. This is the bell staging that we are going to follow. Next condition we will be discussing of the next condition we will be discussing of the neonatal sepsis. Okay, next condition is neonatal sepsis. It could be associated with the early type, it could be late type. If it is less than 72 hours, that is the early type, most of the causes will be from the maternal side. If it is more than 72 hours, if it is more than 72 hours, this is associated with the nosocomial infections. What are the causes, guys? The most common in India, that is today, is E. coli. Okay, E. coli is also old. So if you have to choose between these two, best to choose is the Klebsiella. Next, worldwide. So worldwide, it's still GBS. Okay, it's still GBS that is the most common, followed by the E. coli. This is the two one. And what is the test that you are going to here? That is the sepsis screen. Sepsis screen should be done in this patient. That is the first thing. And next, the gold standard, that is culture. And the treatment, ampicillin plus gentamicin. Ampicillin plus gentamicin. That should be given as a treatment of the choice for the patient. Right? These are the important points, some of the important points, and some basic conditions that you have to remember. Next, what is the normal conditions that we can see? The normal conditions such as melia that is seen due to keratin deposits and erythema toxicum. Erythema toxicum. Erythema toxicum, you are going to see papules and also pustules on the body. And when you do this as a biopsy, not the biopsy, or you can see under the microscopy, you are going to see the eosinophils. That is very easily it going to regress by its own. Next, Mongolian spot. Mongolian spot you are going to see on the lumbosacral region most commonly. Next, Epstein pulse. Epstein pulse is just a white pulse that is seen on the palate. This is also normal. All this will be considered as a normal. Don't have to be worried, and it is go by its own self. Next, when the meconium is passed. Meconium is passed less than 48 hours. When the urine is passed, urine is less than 24 hours. Okay, these simple facts can be also asked in the examination. Next, coming to the three important respiratory conditions that is asked. What is the first condition that you can see here? By the image also you have to identify, right? This is respiratory distress syndrome, which is also known as a hyaline membrane disease. Next, this condition, if you see, this is the lobar fissure. This is seen in the transient tachypnea syndrome, transient tachypnea of neonatal distress. Next, another condition, this is the meconium aspiration syndrome. Okay, this is also known as a wet lung. Overall most common, overall the most common is transient tachypnea. Okay, that is the overall most common. Next, let's see the one by one points. So this is seen in the preterms most commonly. This is seen in the term babies, and it is seen in the post-term babies. Post-term babies. Let's see what are the causes. This is seen in the diabetes mother. Same as here, diabetes mother, whoever is going to cause that infant. And this is seen in, this is also most of the causes will be diabetes mother only, because the diabetes mother can produce the microsomias, and microsomia babies are in the post terms, and that could be also going to cause. Next, other conditions, if there is any, this is associated with the LSCS and also asthma mothers. Okay, mostly prematurity also can be caused for the respiratory distress syndrome. The deficiency main thing here is the surfactant deficiency. The baby cannot produce the surfactant due to preterm. Okay, so that is the one cause. What happens? The lung compliances will be decreased. So baby can't breathe properly. So there is a respiratory distress, and high chance there is a surface tension. So surface tension, what it will do? It will collapse the lungs. So that is why the compliance is decreased. What about here? It is wet lung, as I said. So LSCS patients immediately they can't breathe. So the fluid is filled. So the fluid is filled very transient time. So about like half an hour or 1 hour, the baby can't feel that fluid because the fluid is trapped in the lungs. They can't breathe properly. And here it is fluid itself. Okay, it is fluid itself because of meconium that is gone. So this is aspired. So this aspiration will cause the edema, right? We can cause the edema, and it can progress to the pulmonary artery hypertension will be seen in the meconium aspiration children. On the chest x-rays, you are going to see the whiteout lung. On the chest x-ray, you are going to see the whiteout lung. Just here you can see the whiteout lung, that is completely no air is seen. That is a whiteout lung. Next, here in the chest x-ray, you are going to see the lobar fissure. Just now I written here, right? This is the lobar fissure. Okay, lobar fissure that is seen here, and also sun appearances, sun ray appearances. Here the lungs, just like this, right? Sun ray appearances is seen. Here on the chest X-ray, there will be hyperinflation. Hyperinflation. See, the more air, more blackness is seen. So this is due to wall and halve phenomena. So this is the hyperinflation that you are going to see. That is seen in the meconium aspiration syndrome. What are the treatment of the choice? So treatment of the choice is insure. So in the these patients, it is insure. So what is mean by the insure? So intubate, give the artificial surfactant, and again extubate. This is what the treatment for the patients of the respiratory distress syndrome. And here the treatment will be O2 if they are needed for the O2, but most of the patients will be treated within the 1 to 2 hours or at least less than 24 hours. Here the treatment is oxygen should be given, and also NO should be given because pulmonary tension has been seen. So sometimes we can also use the sildenafil. So sildenafil, why we are using, guys? This is used for the pulmonary arterial hypertension in the babies. This is the Viagra drug, right? Erectile dysfunction patients is taking, but it can be given for the pulmonary artery hypertension. Also, we can give. Next important topic, that is a neonatal resuscitation. Very, very important topic. So whenever the baby is born, you have to check for the term, tone, and breathing. Is the three is available or not? If the three, any one is absent, so you have to check the baby. Something is wrong, breathing is wrong, anything is wrong. You have to check and warm the baby. If the secretions are there, clear the secretions. If the baby is wet, then dry the baby and stimulate. Try to stimulate at the soles region. Even though still the baby is not breathing properly, then check the heartbeat. If the heartbeat is less than 100 per minute, if the less than 100 per minute, you have to attach the positive pressure ventilation. The positive pressure ventilation has to be started with the help of bag and mask ventilation. With the help of the bag and mask ventilation, you have to start the resuscitation of the baby when there is a less than 100 per minute. And even after the 1 minute, if you are still seeing the less than 100 minutes, what you have to do, you have to check for the chest movements of the baby. When the chest movements of the baby, if it is still abnormal, you have to go back and check whether you are doing this correct or not, whether the ECG monitor is showing any abnormality. All you have to check. Then if it is still, it is showing the less than 60 per minute, if it is no improvement, the heart rate is decreasing, ECG is not showing the not properly, then you have to start the chest compressions with the bag and mask ventilation. That has to be simultaneously done. And even after that also you see that is a 60 heartbeat less than 1 minute, then you have to start for the epinephrine has to be started for the baby. Okay, this is how we are going to do the patient's neonatal resuscitation. Even after this also, if you don't see that the baby is still persisting in the 60 per minute, then consider this is a hypovolemia or the pneumothorax. If the baby is dead, you have to declare the death. Okay. Next, some question has been asked from here. What is the 2 minutes target? It is a 70% exposure. And what is the 5 minutes? It is a 80%. After 10 minutes, we will be reaching the 95% of we have to expect it. Next, what is the golden 1 minute? Golden 1 minute is from the baby birth to the positive pressure ventilation. That is here for the golden 1 minute, and this is done for the 30 seconds, and here this will be again is done for the 1 minute. Okay, total within the 2 minutes 30 seconds you have to do this resuscitation immediately. Okay, these are the important points that you have to remember about the neonatal resuscitation properties. Next, we also have the CDH. What is the CDH guy? Congenital diaphragmatic hernia. So, what is the most common type? Most common type is the Bojtell's type. And where you are going to see? On the left side, you are going to see more than the right side. And what is the location? It is going to be the posterior lateral location. Posterior lateral location. What is the treatment? You have to give the IPPV, that has to be started. What is contraindicated? Bag and mask ventilation is contraindicated for this patient. Ultimate treatment of the choice will be surgery only, right? Ultimate treatment of the choice will be surgery only. That is the congenital diaphragmatic hernia that you have to remember, right? Next, moving on to the breastfeeding. This is the nutritional part, and growth and development also we will be discussing here. So the first and foremost important thing when you are going to give the breastfeeding, so the breastfeeding is started as soon as possible. Okay, as soon as possible that the baby is born. Ideally less than 1 hour we have to start it. Okay, this is the first thing that we have to start it. Next, until how many months? So 6 months is going to be the exclusive, not even water also you are going to give. This is for the 6 months, and 2 years is going to be started with a complementary feeding like semi-solids or solids plus breastfeeding, that is going to be started. This is the questions is also asked. How many months? These are the and how many months important complementary points and that the is also diseases asked. That you have to 6 months and the remember in 2 this years. Condition. This is the first Those who are thing new that to you this have to channel, remember. Please do subscribe. Next, absolutely which patient should not be taken? Which patients that these drugs is this breastfeeding is not given? One is lactose intolerance, because lactose intolerance can cause the triggering of the allergic reaction. We should not give galactosemia because the lactose cannot convert it. So this is also not given. And also the mother who is taking the chemotherapy is highly toxic. Baby immune system is very less. So chemotherapy patients is also not given. Relative conditions. What are the relative conditions? Relative condition, those who are taking the TB drugs, and also HIV, high viral load. This is also not given for the mothers. Right, these are the some of the relative indications that we are not preferring for the breastfeeding. But how we are going to guide for the HIV mothers? Mostly if there is a donor human milk, okay, if there is a donor human milk, you can give. But even the mother who is a HIV also you can give. Breastfeeding is allowed. Nowadays it is allowed. So, but we are going to check whether the mother is belongs to the high risk or the mother is going to belongs to the low risk. We have to check. If the mother is high risk, that means mother is does not taking the treatment, and mother is having the viral load more than 1000. That mother is taking the treatment, okay, and viral load is less than 1000. Then we can choose the dependence on. So if it is a high risk, we are going to give the nevirapine plus zero drug for the 12 weeks. If the mother is taking the low risk and treatment is given, then only one drug, nevirapine, for 6 weeks. That it has to be given. This drug is given for the baby, not mother. Okay, this treatment means that in the pregnancy they have taken. That is for the HIV patients. That's how we are going to use. Next, what is the best position? So mouth has to be cover the areola, lips are plunged out, and the chin has to touch. Okay, chin has to touch, and after that the baby should burp. Okay, baby should burp. If the burp is not heard, high chance the baby can die within the sleep also. But GERD can be seen, vomitings can be seen, dehydration will be seen. So the burp should be done for the baby after breastfeeding. So you have to guide in your internship also. That is the most important thing that we have to do as a doctors. Next, coming to the breast milk contents. So the first 2 weeks we are going to see the colostrum. Colostrum is seen in the babies, which will be highly fatty IgA, vitamin A, which will be present in the 2 weeks of the colostrum. Next, we will be having until 6 weeks, that is 6 weeks to 14 weeks also, that is a transitional milk. That is the transitional milk that is present here. Transitional milk is just the from the colostrum, it is has came with a transitional milk, and more than 14 weeks, let's say this is the mature milk that you are going to get, and you have to swipe between the two breasts. Not one breast has to be given 15 minutes one breast, 15 minutes another breast, that you have to given for the baby. If it is only one breast, likely to be patient going the baby is going into the dehydration. That is the first thing that you have to remember. And what are the properties that the milk contains? It contains the lactase, it contains the whey protein, and it contains the DHA and arachidonic acid. These fatty acids is also present, and proteins like taurines and cysteine. Okay, this is both are important for the brain maturation. Okay, and they also contains the lactoferrin and IgA, bifidus factor. This is important for to fight the bacterial infections and microbiota, right? These are important points for the milks that contains. How much is the calories that the milk? 67 kilocalories per 100 ml of the milk. So this is how the milk properties, breast milk properties that you have to remember. And how many hours we can save this breast milk? So if it is room temperature, if it is a room temperature less than 24 hours. If it is in the refrigerator, in the home side refrigerator, sorry, if it is a room temperature, 6 hours. If it is a fridge, in our home fridge, then it is 24 hours. If it is minus 20 degrees Celsius, then it is 6 days. Okay, maximum is 6 days can be also saved. So this is how we are going to save. And is it same with the every baby that we are going to give? No. So feeding will be depends on the aging also. For example, less than 28 weeks. If the baby is born less than 28 weeks, go for the IV. That means total parenteral nutrition. If the baby is less than 32 weeks, the baby is less than 32 weeks, then go for the MGT or the OGT. If the baby is more than 32 weeks, but less than 34 weeks, let's say, then you have to choose the Katori spoon or the Paladile spoon. If the baby is more than 34 weeks, then we can start with the breastfeeding that can be given for this baby. The first thing, these are the important points that you have to remember. Next, let's see hypoglycemia, how we are going to manage with the hypoglycemia of the baby. So the normal hypoglycemia limit for the babies, normal babies, this is less than 45 milligrams per dl. Okay, if the baby is having the no symptoms, or if the baby is having the symptoms. If the baby is having the symptoms, then you have to give the IV insulin, sorry, IV glucose, hypoglycemia. If the baby is having the asymptomatic, let's see, is it less than 20 or more than 20? More than 20, no symptoms, breastfeeding should be given immediately, like oral glucose. If it is less than 20, again go for the IV glucose. This is how we are going to treat. Next, hypothermia. Hypothermia is considered as a less than 36.4. Okay, less than 36.4 Celsius. Let's see the baby is stable or the baby is unstable. If the baby is stable and the baby is premature, what you can do for this baby? Then we can go for the kangaroo mother care. Okay, kangaroo mother care. So skin to skin contact. This is going to cure with the help of the conduction principle. And unstable babies, we are going to use the warmer in the government hospital, and in the some of the hospitals there contains the incubator also. But what are the mechanisms behind this warmer and the incubator? The incubator is about the convection and this is about the radiation, right? This is how we are going to treat the hypoglycemia and the hypothermia. These two questions is recently asked in the NEET PG questions also. Okay, that has to be reminded. Next, let's see some of the important points about the growth. Whenever there is a growth, there is a graph that you have to remember. So these are the different colors I'm going to give. Everything will be meeting at one point. Okay. So let's see one by one. So first, this is the A. Okay. So this is the lymphoid tissue. So how can I say lymphoid tissue? So this is the age and how much is increased. So this is the birth. Let's say this is the 12 years plus. Okay, this is less more than 12 years. So lymphoid tissue like tonsils, we have only incidence up to 12 years, right? After that we can't see. Adults don't have the most of the tonsillitis, right? After the 12 years the lymphoid tissue will drop. Next, this one, this is the B, and B is for the brain. Okay, the maximum brain tissue that we can grow is only until the 2 years. So here only. So after that is going to constant. So this is the B, this red color one. Next, that is a C. Here you can see this is a C. There is a 2 points. It is elevated here and here. That means this is a growth. Growth has the two times of the growth. This is the first growth spurt and this is the second growth spurt. Next, this one is after 12 years, after 12 years only it is increasing. So this is about the gonads, gonadal growth. So these are the important points that you have to remember. Next, what are these two charts, guys? This is used for the boys for the growth assessment. This is used for the girls. Okay, WHO growth charts that we are going to use for the different parameters. For example, let's say that the baby is having the acute malnutrition. Acute malnutrition means she is having the wasting. With the help of what we are going to check, we are going to check with the weight to height. Next, chronic malnutrition is how the baby will be stunting. So with the help of the height for age, we are going to check. So these are the two important charts we are going to check, depends on the patient's presence, right? Next, what is the normal weight? So when birth, on the birth, the normal is 2.9 kg. Okay, 2.9 kg. And when it is going to decrease, so 10% of the weight loss is seen and they will regain on 10th day. When it is going to double, this 2.9 kg, let's say 3 kgs, when it is going to double, it is double at the 5 to 6 months. When it is triple, at the 1 year. When it is 4 times, it is going to be at the 2 years, right? Next, let's see height. Height normal is the 50 centimeters at birth. When it is going to double, guys, it is going to double at 4 years. Okay, it is going to double at the 4 years. It is going to be double. Next, 3 times. That means 150 centimeters. It will be at the 12 years of the age. What about 1 year? At the 1 year of the age, the baby will be having the 75 centimeters. That is going to be 75 centimeters. At the age of 2 years, that is 87.5 centimeters. That means half of our Adults is 160 or 150 only. So half of it will be at the 2 years of the age. Next, we also have the some other important points, that is the head circumference. In the head circumference at birth, it is the 33 centimeters. And by the 3 months of the life, it is going to be 2 centimeters per month. And by the age of the 6 months, it is going to be 1 centimeters per month. And more than 1 year, it is going to be 0.5 months per month, 5 centimeters per month. Okay, this is how it is going to be presented. By the age of the 12 years, you are going to have the 53 to 56 centimeters of the head circumference you are going to see. And what are the microcephaly causes? Microcephaly causes. Microcephaly causes are most commonly, you all know that, that is the alcohol syndrome, the mother those who take the alcohol syndrome, so the fetal alcoholic syndrome, and also Zika virus, and multiple torch infections, and Rett syndrome. Okay, Rett syndrome after the growth. So all this will be associated with the microcephaly. Next, we also have the mid upper arm circumferences. Mid upper arm circumferences. This is going to have the Shakir step. So this is used with the help of the Shakir tape, which has the different colors. So green color is considered as a normal, more than 12.5 centimeters. Yellow color we have, this is going to be moderate type of the malnutrition, less than 12.5 centimeters. Next, we also have the red color. This is the severe condition, which contains of the less than 11.5 centimeters. This is for the mid upper arm circumferences that we are going to check for the babies. Then we have to diagnose for the babies, those who are suffering from the severe acute malnutrition. How we are going to check severe acute malnutrition by the WHO definition, that the babies will be presence of the edema, first thing. And the second thing, the babies will be having the weight to height charts. You are going to see less than 3 standard deviation, that is present. And mid upper arm circumferences less than 11.5 centimeters, that is going to see. If anything, if anyone with the edema is present, then we have to consider the baby for the SAM, that is a severe acute malnutrition baby. So the main categories of this both is the marasmus and the kwashiorkor. So the marasmus babies will be having the severe linear. Okay, they are so much of the linear. Why? They having the protein deficiency as well as calorie deficiency, and these patients is only having the protein deficiency. That's why the baby is having this protuberant, because the albumin is hypoalbuminemia. So the baby is having the edema, that is seen in the protein deficiency condition of the kwashiorkor, which is the more severe condition. So the protein deficiency is the more severe rather than this patient. And what are the other features that you are going to see? Severe muscle wasting, and also emaciated and disproportionate head size, that is seen in the marasmus, and prominent cheeks, which we call as a moon faces, fatty liver is seen, dry and peeling skin, pitting edema. All this will be seen in the kwashiorkor patients. And these both patients will be also having the other peculiar features like appetite. So appetite will be present in this patient. There is no appetite is present in this patient. Okay, this patient is alert, this patient is dull. Okay, this is how they are going to present it. And these skin features, this is known as a flaky dermatitis. This is known as a flaky dermatitis. And on the hair, you're going to see the flag sign. Different colors of the hair will be seen in this patient. What is the hypoglycemia index for this patient? We can keep for the upper limit only. Okay, less than 54 milligrams per dl. We have to keep. Why we have to keep this much, guys? Because if it is even more less than, they can have the seizures also. And how we are going to treat? Always you have to treat with the IVNS plus 5% of the dextrose. Why I have added the NS? Because there are multiple electrolytes dysfunction is also seen in this patient. And how we are going to treat? We have the two phases. One is the stabilization phase. One is the stabilization phase. This is for the 1 week, and followed by we are going to do the rehabilitation phase. Okay, this is for the 2 weeks. Almost 4 weeks we are going to treat these babies. Okay, so 2 to 6 weeks, 1 month in between that, 4 weeks, 2 weeks, 6 weeks, you can take for the stabilization phase for this baby. Okay, and there is a syndrome, refeeding syndrome. Refeeding syndrome. What happens in the refeeding syndrome? Suddenly the baby is having the problem with the malnutrition. Okay, once we counsel the mother, please give the food to the baby. So then given the sudden surge of the food, okay, sudden surge, let's say sudden calories in the body. What happens to these sudden calories? This will increase the glucose levels. Eventually, this will increase the insulin. So once the insulin is increased, all the phosphate, magnesium, potassium, and sodium, all this will enter the cells, okay, inside the cells. So what happens in the vascular? There will be decreased potassium, decreased magnesium, and decreased potassium. All this will be seen. Phosphorus will be decreased. What is the most important one? So the most important one among them is the phosphorus. This question is asked in the recent INICT examination. So please don't give up this on this question. Okay. Next, we will discuss the milestones. All the important milestones that has been asked also we will be discussing. Only important milestones we will discuss. So first and foremost, they are the gross milestones, right? Milestones. This is about the body movements, right? At the age of the 3 months, the baby can properly neck hold. This is seen. At the age of the 6 months, the baby can sit with support. Okay, most of the times at early age, there will be sitting with support in the tripod posture. Next, at the 8 months, they are going to sit without support. At the age, they are going to sit without support. Next 10 months, they are going to stand in their position with support. Okay, always some milestone is coming, always they are going to take the support only. Next, at the age of the 12 months, they can stand without support. Okay, the babies can stand without support. Next 15 months, the baby can walk without support. Okay, the baby can walk without support, but as I said, they have to take the support, right? So while they stand without support, they will walk with support. Here only they will walk with support. Okay, after the 15 months, when they are going to run, they are going to run at the age of the 18 months. At the 2 years of the age, the baby can walk the stairs. Okay, baby can walk the stairs. At the 3 years, the baby can tricycle. Tricycle riding will be seen. At the 4 years, the baby can hop. Okay, hopping will be seen. So these are the gross motor type. Okay, next we will be seeing the fine motor using the fingers and the hands. At the age of the 4 months, there will be bidextrous grasp. They use the two hands to grasp any type of the object. And at the age of the 6 months, they will be having the unidextrous grasp. And at the 9 months, this is going to be the immature pincer grasp, means using the fingers. And at the 12 months, you're going to see the mature pincer grasp. Okay, mature pincer grasp. Right, these are the important points of the fine motor. And what are the lines they are going to use? At the 2 years, 2 points. Okay, 1 and 2 point. So that is for the 2 years. And at the age of the 3 years, they are going to circle. At the age of the 4 years, they are going to write 4 points. At 4.5 years, they are going to draw the square or the rectangle. At the 5 years of age, they are going to draw the triangle. At the 6 years of the age, they are going to draw the rhomboid, or the different kinds of the shapes can be seen by the baby. Okay, this is for the fine motor skills. Next, we have the language skills, when the baby will be speaking the different languages. At 3 months, cuckoo. At the 6 months, there will be monosyllables and also stranger anxiety. The baby will be having the stranger anxiety. And at the 9 months, the baby will be telling of the bisyllables. Okay, bisyllables will be seen. And at 1 year, the baby can speak the 1 to 2 words. Okay, this is asked in the recent INICT. And at 18 months, they can speak the 8 to 10 words. Okay, 8 to 10 months. And 15 months they are going to speak the jargon speech. Jargon speech means we can't understand what they are speaking. At 2 years they can tell the sentence at least one to two. Okay, one to two sentences will be seen. And 3 years they will tell about their name, about their sex, and about their age. And by the age of the 4 years they will go toilet by themselves. Okay, this is not the language, but I'm just adding to remember for the important point. Okay, these are the important points. And next, at the age of the 9 months only, you're going to see the peekaboo. Okay, peekaboo is seen in the 9 months. And 4 years, they will play with friends. Okay, they will play with friends in the groups. They are going to play with the groups that you are going to see. These are the important milestones that you have to remember. Social is not seen much, but the social you can, which will be given with the other types only, that you can easily remember and recall. Okay, these are the important points about the nutrition, growth, and development that we have discussed. Next, moving on to the systemic diseases. So first and foremost important one, that is the Kawasaki disease. Kawasaki condition. In the Kawasaki disease, the patients will be suffering of the vasculitis, right? This vasculitis, which will be involving the small vessel, and sometimes median vessels also involved. What is the most common artery that is involved? Coronary artery. Coronary artery. And how this is going to be presented? So the patient will be having the fever. Okay, fever will be seen, which is more than 5 days, and that is not responding to the any treatment, not even pyretic treatments also. This is not responding. Okay, best to choose the median, guys, because it is directly involving the coronary artery. Best to choose the medium vessel vasculitis. Next, fever is more than 5 days. Okay, fever is more than 5 days with non-purulent conjunctivitis. Okay, this is the important line. Non-purulent conjunctivitis. If it is a purulent, obviously that is a infectious. This is a non-purulent. Next, the rash. Rash will be polymorphic and no vesicles is seen. Non-vesicular rashes. Next, edema. Edema in the lower limbs, edema in the fingers, edema will be in the subungual regions. All this you are going to see. Next, cervical lymphadenopathy. Unilateral side. Only one side you are going to see. And next, periungual peeling. Okay, periungual peeling will be seen. Plus, you are going to see the strawberry tongue. Strawberry tongue. All these symptoms will be given. Next, ESR and CRP is elevated. On the echo, you are going to see the aneurysms. Microaneurysms will be seen. Microaneurysm will be seen in this patient. And antibodies, those antibodies are endothelin antibodies. Anti-endothelin antibodies will be seen in this patient. And how is the treatment is given for this patient? For the inflammation, you are going to use the aspirin, and also for the anticoagulation, you are going to use the aspirin. Best drug is the IVIG. This is the drug of the choice. If there is a IVIG resistance, then we can start the patient on the steroids. So this is how the Kawasaki disease will be presented. Okay, here you can see non-purulent conjunctivitis, strawberry tongue, unilateral lymphadenopathy, peeling, here also peeling, and erythema, and the baby is having the conjunctivitis, and here also peeling. So this is how the baby will be presented of the Kawasaki disease. Next, coming to the rheumatic heart disease. So what is the most common for the rheumatic heart disease, guys? So the first and foremost, what is the cause? The most common cause will be the post-strep infection. Okay, this is not the strep infection. This is the post-strep infection. And in this post-strep infection, this will cause the cross reactivity. Okay, this word is also important. And molecular mimicry. Molecular mimicry. These both, this molecular mimicry and cross reactivity will produce the different types of the antibodies. And these antibodies will kill or attack on the organs. Normal organs, it is going to be acted. And if it involves the heart, that is going to convert it as a rheumatic heart disease. That is how it is going to be presented as a rheumatic heart disease. What are the organs that is involved? Remember with the mnemonic of the Jones, and that is also our major criteria. What is the major criteria? That is Jones. Jones criteria. Jones criteria. Jones for this is for the joints. The patient will be having the arthritis. And O is for, let's say, this is for the heart, carditis. And this is for the nodules. And this is for the erythema regions, especially erythema marginatum. And this is for the Sydenham chorea. Okay, involving the brain. Okay, involving the brain. Next, what is the major criteria? Whenever I say major criteria, this is a severely this molecular mimicry or the antibodies is attacking. So we have the different type of the carditis. First one is the endocarditis. So these endocarditis will involve the valves. Okay, so the valves will be involved, the lesions. If it is involves the myocarditis, so the patient will be having the ECG changes. This is also seen in the ECG changes. And also pericarditis. Pericarditis, the patient will be having the pain, right? On histology, you are going to see the Askov bodies. I discussed this Askov bodies in our pathology lecture. Histology will show the Askov bodies. And what is the treatment for this patient? The treatment for this patient is the penicillin. The treatment for this patient is the penicillin, right? This is the most important point that you have to remember. And if the patient is developed the heart disease, so the first and foremost, mitral regurgitation, mitral valve is most important. If it is complicated, then it is converted as a mitral stenosis. So mitral regurgitation is the early and mitral stenosis is the severe. Okay, followed by another valve that is involved, that is the aortic will be involvement. And how you are going to treat penicillin, as I already said, but what is the prophylaxis? Okay, prophylaxis. So prophylaxis, if the patient is having the rheumatic fever, okay, but no carditis, you have to give the penicillin for 5 years to whichever is the highest, 21 years or more. Next, rheumatic fever is seen, also carditis also seen. Anything, either endocarditis, myocarditis, pericarditis, anything is seen. Then for this patient also you have to give the penicillin for 10 years and whichever is highest, 21 years or more. Okay. Next, rheumatic fever is seen, carditis is seen, and also this lesions is also developed. Let's say the patient is having the rheumatic heart disease also. Then also you have to give the penicillin for 10 years continuously and lifelong. So this is how the classification of the rheumatic heart disease. Okay, we are going to follow. Just this is the important points about the rheumatic fever that you have to remember. Next, moving on to the cardiac diseases. In the cardiac diseases, we have to divide as a cyanotic heart diseases and the acyanotic heart diseases, right? These are the important. So how the normal flow will be seen, oxygenated and the deoxygenated, guys. So just a glimpse how the oxygenated and the deoxygenated blood will be seen. Oxygenated blood will be coming from the pulmonary ventricles to the left atrium to the aorta, right? Next, deoxygenated blood from the pulmonary arteries from the right atrium, and it is going to side right atrium to the pulmonary arteries and pulmonary veins to the left atrium to the aorta. That is how the circulation will be seen in the oxygenated and the deoxygenated. So if this circulation is breaked, that is going to converted as a patients with the heart diseases, congenital heart diseases. Okay, so we have the cyanotic diseases and acyanotic diseases. Let's see. So cyanotic types. The most common overall is the acyanotic. Okay, this is the most common overall. And in this we have the AST, VST, patent ductus arteriosus. This is the most common in the acyanotic, and in the cyanotic we have the tetralogy of Fallot we have, and TAPVC and TGA Okay, transposition of the great arteries, all this will be seen in the cyanotic heart disease. In this cyanotic, the most common will be the TOF, tetralogy of Fallot. This is the overall, guys. Overall will be the AST types. Okay, here you can see AST. So AST, where is the shunt is happening? So the deoxygenated blood is mixing with the oxygenated blood. Okay, so the shunt will be from the right side to left. Okay, right side to the left side. So there is no problem. Okay, these patients will be having the acyanosis. No cyanosis will be seen. Next, ventricle also. So the ventricle also, the shunting will be seen from the, sorry, so the shunting is deoxygenated blood is shifting to the oxygenated blood. So there is no problem, right? Again, it will be oxygenation will be seen. So same again. So the deoxygenated is mixing with the oxygenated. So there is no problem that will be seen in the ventricular septal defects. So ventricular septal defect, what is the most common subtypes? So the subtypes is the ostium secundum. Ostium secundum is the most common subtype. Ventricular septal, this is the most common type of the membranous. Membranous type is the most common type of the ventricular septal defect. So tetralogy of the Fallot patients will be having a multiple defects. So the most common and most important one is the substenosis, substenosis of the pulmonary. Substenosis of the pulmonary, then followed by the VST, followed by the right ventricular hypertrophy, and aorta is not giving the chance. So aorta is having the overriding of the aorta is C. So that's why the patient cyanosis is actually caused by the substenosis or the pulmonary stenosis. Next, aortic coarctation of the aorta. This is seen in the patients of the Turner syndrome. Okay, this is seen in the patients of the Turner syndrome, and the pulse is difference in the upper limb normal and lower limbs is decreased, and BP is decreased here and BP is raised in the upper limb. So this is the difference in the aortic coarctation. And another important points, in the AST patients you are going to see the ejection systolic murmur, and there is a split in the S2 which is fixed. And in the VST patients, you are going to see same systolic murmur, okay, but followed by the diastolic murmur also, okay, followed by diastolic murmur, and it is wide S2 split, wide S2 split, which is partial also. Next, PDA, patent ductus arteriosus. For these patients, it is going to be the continuous murmur. Okay, it is going to be the continuous murmur. For this patient, the drug of the choice is ibuprofen. Ibuprofen can easily close the patent ductus arteriosus. Okay, these are the some of the conditions. Let's see some of the pictures here. So what is this condition, guys? This is a tetralogy of Fallot. Tetralogy of Fallot. So this is the RVH, right ventricular hypertrophy, overriding of the aorta, and subpulmonic stenosis. This is a tetralogy of Fallot. And here, this is the box-shaped heart, especially this is the lithium exposure by the mother, Epstein's anomaly. Okay, Epstein's anomaly. So in the Epstein's anomaly, the right ventricle is going to be having the defect. Okay, so that's why you're going to see the box shaped heart. Next, this is the pulmonary artery and pulmonary venous malformation, and this is the uh, skim skimter's sign. Okay, the knife sign, or you can say dagger sign also, where you are going to see the pulmonary artery and the pulmonary venous malformation. Okay, this is the partial, and if you see that is a severe, okay, total pulmonary, this is a total anomalous pulmonary venous. In this total anomalous, you are going to see 8 shaped. Okay, 8 shaped is seen in the total arterial pulmonary venous abnormality, total anomalous, where you are going to see. Next, this is the TGA. This is the transposition of the great arteries. So how the aorta is connected to the which valve? Aorta has to be connected to the right ventricle. Instead of it is it has to be connected to the left ventricle, but it is going to connected with the right ventricle. And coming to the pulmonary artery, it is connected with the left ventricle. So this is the abnormal, that is the TGA, and where you are going to see the egg string appearances, egg on string appearances. Next, this is the coarctation of the aorta. Coarctation of the aorta, it has to supply, right? It is not supplying. So what happens in the coarctation of the aorta? Mostly these patients will be having a collateral circulation. These collateral circulation will damage the ribs, will damage the ribs. So these are the some of the important images that you have to remember. Next, coming to the IMNCI guidelines. IMNCI guidelines that we have to take note. So first we will discuss the pneumonia. First we will discuss the pneumonia, guys. So we have the three different colors, right? One is the green and other one is the yellow category, and the next one is the pink color. Different categories, right? Let's see one by one. So in the green categories, this is the no pneumonia. So baby is not having any pneumonia. Then this is the moderate pneumonia. That means pneumonia is present. It's not like moderate, the pneumonia is present. And this patient is having the severe pneumonia. This patient is having the severe pneumonia. So what are the, how we are going to differentiate? We are going to differentiate. This is going to have the just cold symptoms. And here the baby is having the chest indrawing, or baby is having the fast breathing. But SpO2 is absolutely normal. This is the differentiating between the third pink color and the yellow color. And here also chest indrawing and fast breathing is seen, but SpO2 is significantly decreased in the babies. And also you're going to see the signs of danger signs. Okay. For example, the baby is having the seizures, convulsions, and baby is having the dehydration, right? All these are the danger signs that is seen in the pink color. Then how we are going to treat these babies? So the first babies, it treat at home only, symptomatic treatment is given, and these babies the treatment is oral antibiotics. These babies is having the oral antibiotics can be given, and follow-up should be given by the less than 3 days. These babies the treatment is first antibiotic is given at the PHC, and then higher hospital refer for the higher hospital center that has to be done for these babies. And what does mean by the fast breathing, guys? What does mean by the fast breathing? As per the WHO guidelines, the fast breathing is three types. Okay, so the first one is if it is more than 60 per minute, this is for the less than 2 months, and more than 50, this is for the 2 months of the 1 year, and more than 40 per minute, this is for the more than 1 year. Okay, so this is the fast breathing that you have to apply for the complete guidelines when you are checking for the IMNCI. Next, IMNCI guidelines that you have to know about diarrhea. Okay, diarrhea you have to check. So same again, I'm going to use this one only here. So let's see, guys. So in the green color, these patients is having no dehydration. Okay, no dehydration, and the baby is alert. We just remember with the what are the types we are going to differentiate these babies, and these babies is having the some dehydration. That means we can say these babies is having the mild to moderate. Okay, let's consider this is a mild to moderate dehydration. So babies will be having the irritable, okay, thirsty is going to be seen in these babies. Okay, next, this is the severe type. Severe dehydration, capillary refill time will be, it should be less than 2 seconds, but unfortunately this babies is having very much more than 3 seconds. And also completely dry mouth not even thirsty and lethargic. Plus again, same danger signs can be seen here also. Danger signs is seen here. What is the treatment then? So for these babies, the treatment is oral fluids. Oral fluids such as mother's milk, so breastfeeding, or the rice inside the rice water from our home, rice water that can be also given for this baby. Next, for the moderate dehydration babies, what we have to do? We have to start the baby on the ORS. Okay, ORS can be given 75 ml per over the 4 hours. You have to give this patient. This is known as a rehydration solution. And also other oral fluids like breastfeeding is still given for this baby. Next, danger signs baby. In this danger signs baby, you don't have to give the ORS. Always go for the IV fluids. How much you have to give? 100 ml. Okay, 100 ml over the hours you have to give for these babies. Okay, this is the pattern that we are going to follow for the severe type of the conditions. Along with that, you have to use the daily fluid requirements. Daily fluid requirements is also considered here. How we are going to calculate the daily? We are going to use the holiday cigar method. Holiday cigar method. So in the holiday cigar method, these babies is classified under the three classifications, guys. Is the baby is 0 to 10 kgs, or the baby is more than 10 kgs, or the baby is more than 20 kgs. So this is how we are going to give 100 ml per kg up to 10 years. Okay, up to 10 kgs. So here 50 ml per kg and here 20 ml per kg. That means this 1000 ml will added here, and here 1500 ml is added from here and from here. So this is how the normal daily requirements depends on their kgs and weight we are going to consider, right? This is how we are going to calculate. Next, another important ORS. How the ORS is given? What is the classification of the ORS? Can I give the ORSL? Can I give the ZSL? These are the stupid brands. This should not be given. Okay, and we also have to awareness around our people, our family, our society. We have to tell this should not be given. This can cause a shock to the baby. So, what is the normal ORS classification? What is the normal ORS? So, normal ORS is consisting of the 245 to 250 milliosmoles of the osmolarity, and this works by the SGLT2, SGLT2 and SGLT1. From there, there is going to be the absorption, right? So the composition here will be sodium, potassium, glucose, and also there will be consisting of the chloride and citrate. Somewhat the sugar is also present. Sodium will be 75 milligrams. Potassium is going to be less. We have to keep this less. Okay, 20 only. And glucose is another 75 mg. Okay, and chloride is 60 and citrate is 20. So this is how the ORS is made for the diarrhea patient, and this has to be only the configurations that should be present. More than this or the more than less than this, that can cause a significant distress and shock in the babies. Next condition. So this is the bronchiolitis. This baby is suffering from the bronchiolitis. Most common organism RSV, respiratory syncytial virus. And for these babies, mostly they will be infected by the 2 to 5 years of the age. Okay, 2 to 5 years of the age. What happens in these babies? There will be pneumonia only. Okay, pneumonia. But this pneumonia is involves the bronchioles, severe bronchioles involvement, and it can cause the obstruction. So the babies will be having the wheezing rather than of the pneumonia, other classical pneumonias which will be consisting of the crackles, right? Next, on the chest X-ray, if you observe, so there is a more air shadow. There is no consolidations or there is no any infiltrates also. So these babies on the chest X-ray, which will be showing of the hyperinflation. Okay, hyperinflation will be seen in this patient. What is the treatment of the choice? Treatment of the choice will be most of the viral infections, not only the bronchiolitis, many viral infections is supportive only. And if the baby is having the severe condition, we can give the ribavirin. Okay, ribavirin can be given for these babies. So this is how we can give and treat these babies. Next, another condition is asthma. So in the asthma patients, we all know that the babies will be having the severe hypersensitivity. Okay, severe hypersensitivity. Most of the times there will be extrinsic factors like exercise, dust, or intrinsic factor from the family. Atopy, ATP, right? Atopy and IgE. All this will be causing the babies more prone to the asthma. So what is the treatment of the choice that we have to give for these patients? So as per the GINA guidelines, for the babies also, we have to approach the step ladder approach only. If the baby is having the symptoms like less than 2 episodes per week or 2 episodes per week with or without nocturnal episode. So here you are going to add the low levels of the bronchodilators, right? Low LABA will be added. Along with that, steroids is showing the significant improvement. So we are going to do. And if it is a moderate, then we have to increase the dose. LABA plus ICS. This is how we are going to follow the babies, right? If they are having the acute episode, sudden onset of the acute episode, for this we have to give the short acting SABA, that has to be given immediately. If they are having a severe episode, for this patient we have to give the oral steroid and SABA, and sometimes we can also give the MGS44 if it is not controlled. Then we can also give the MGS4 for this babies. Next, monoclonal antibodies. Monoclonal antibodies. What are present? Duplizumab. This is for the IgE. Okay, duplizumab. Sorry, this is for the IL-4 guys. IL-4. Next, omalizumab. This is for the IgE. Next, benzralizumab. Benzralizumab. This is for the IL-5. Okay, these are the important monoclonal antibodies is also given for this babies. Next, another condition, that is a cystic fibrosis. Cystic fibrosis is an autosomal recessive condition. CFTR is absent in this patient. This involves the 7q chromosome, and at the 708 position deletion due to phenylalanine, it can also cause this condition, cystic fibrosis. What is the defect of the cystic fibrosis? CFTR gene. This CFTR gene is a channel. Okay, this is a channel and very much important for the Cl and sodium levels. Okay, if this is having the defect, obviously there is a chloride clearances and also sodium clearances will be decreased in the body. That is the CFTR. So most common organ that is involved is the lungs. Okay, that is why this condition is also known as a monoviscodiosis. Okay, mucoviscodiosis is also known as due to involvement of the lungs. So what happens? The baby can develop the polyps, the baby can develop the aspiration, okay, and severe mucus production. If more and more mucus is there, recurrent pneumonia is seen in these babies, and pneumonia is associated with the staph aureus. Okay, staph aureus most common. But if the baby is having the severe, that is due to pseudomonas. That is due to pseudomonas. So even death can be also seen in the pseudomonas conditions. And the second most common, which will be involving of the pancreas, which will be increasing of involvement of the pancreas insufficiency. Obviously there will be ADEK, fat soluble will be not used, and the baby can also have the malabsorption, and sometimes they are also going to present the meconium ileus. Okay, meconium ileus, and in the adults it can be presented as a infertility. Okay, infertility, because vas deferens. Vas deferens is absent. By birth only, they are not going to have the vas deferens. This is also seen with these conditions. So how you are going to treat this patient? CFTR modulators. We have the new drugs. So these are the CFTR modulators which ends with the kaftar, Eva kaftar. Okay, Eva kaftar. How you are going to treat with the help of the Eva kaftar? How you are going to diagnose? We are going to diagnose more than one, more than two or equal to two. You have to do the sweat chloride test. Okay, sweat chloride test. And if this sweat chloride test is showing the 60 milliequivalents, more than 60 milliequivalents in the two episodes, then we have to confirm the diagnosis. And other than that, the best one is the CFTR gene itself. Okay, CFTR gene itself, you can check for the treatment. That is more confirmatory. So this is the overview of the cystic fibrosis. Next, another condition, that is celiac disease. Celiac disease. So celiac disease is basically is about the gluten sensitivity. Okay, gluten hypersensitivity. So what happens in this gluten hypersensitivity, guys? So whoever taking the bro, what is this bro? Barley, rye, oats, and wheat. If this is not sensitive to our intestines, they are going to have the gluten hypersensitivity. So the patient presentation will be diarrhea, iron deficiency, anemia, and malabsorption. Okay, malabsorption. Constipation can be also seen in these patients, and weight loss. If it is a baby's, failure to thrive, failure to grow, this will be seen. Right, these are the some of the symptoms. And on the diagnostic test, this is important. There will be HLA positive, especially DQ2 and DQ8. And on the antibodies, there is a TTA antibodies is present. That means this belongs to the IgA. And also endomysial IgA is also positive in these patients. The best one is a biopsy. Okay, this is the best and gold standard. Okay, these are the more sensitive. These are the more sensitive. And on the biopsy, you are going to see the crypt hyperplasia, and along with that, there will be infiltrates, lymphocyte infiltration, and the most common will be villus atrophy. All the villi will be atrophied. This grading is known as a Marsh staging or Marsh grading. And what is the treatment of the choice? Just avoid the gluten. Gluten should be avoided. What is the skin condition that is associated with this patient? The skin condition that is involves is the dermatitis herpetiformis. Dermatitis herpetiformis. Okay, that is the one of the conditions is the associated with the celiac disease, right? These are the important points of the basics about the pneumonia, and I will say guidelines on the gastrointestinal and the respiratory conditions. Next, moving on to the this picture you might have already seen in the other lectures like micro. So for the bacterial, as I said, there will be increased neutrophils, and for the tuberculosis, increased lymphocytes. And severe protein is increased, tuberculosis. Mild protein is increased, bacterial. Severe glucose decrease, that is a bacterial. Turbid color, and here the cobweb formation that is seen in the tuberculosis. This is how you are going to classify. Next, newborns. What is the cause? As I said, GBS and Klebsiella. Klebsiella is India, and this is the world. Next, less than 2 months. Staph aureus. Hib. Hib is rarely seen, guys. We cannot consider here. Hib and Streptococcus pneumonia or Listeria. Next, more than 2 months is going to be Hib, Streptococcus pneumonia. Okay, more than 1 year to 2 years. It could be associated with the strep pneumonia and Neisseria species. This species also important that you have to remember. Okay, I said the difference is only for the newborns. Remaining all are same for the worldwide and also in the local. Next, congenital infections, which is associated with the torch infections. Okay, so these are intracranial. These are intracranial calcifications. Where is this intracranial calcification is seen, and other symptoms also I will tell. These patients will be having the chorioretinitis. Chorioretinitis. This patient is also having the hydrocephalus, and plus or minus they will be also having the hearing condition. So this is seen in the patients of the toxoplasmosis, right? What is the test we do? Sabin filament test. Next, coming to the another condition, these are the ventricles, and you are seeing the calcification. This is the periventricular calcification, right? Periventricular calcification that you are seeing here. Along with that, the baby is having the CSNHL and also glaucoma and retinitis. This is the most common overall CMV. And how you are going to diagnose? With the help of the PCR. What is the sample that you are going to take? Urine. Okay, this one. Next, this is a severe condition. This is the most severe. And what is this you are going to see? This is the leukomalacia. In around the ventricles, this is the ventricle that you are seeing the leukomalacia. And other symptoms, the baby is having the cataract. Baby is having the patent ductus arteriosus and SNHL. This triad is seen with the severe conditions, that is the rubella. That is the rubella condition. Next, this is the microcephaly. The baby is having the microcephaly, and baby is having the limb defects, and also baby is having the contractures, and this condition is Zika virus. Okay, mosquito borne, only mosquito borne seen in our pregnancy is, that is this condition. Okay, microcephaly and all this due to Zika virus. That mosquito is the Aedes mosquito that is involved in this patient, right? Next, another important points are seizures. Okay, first we will be seeing the febrile seizures. This is the most common overall. This is the most common overall all the seizures. And how you are going to classify the febrile seizures? Febrile seizures are classified into the simple. So that means the baby is having the 24 hours of the fever, less than one episode, and that episode is less than 15 minutes. And other type is a complex. This is more than 15 minutes, more than two episodes in less than 24 hours. Less than 24 hours, two episodes is seen. That is a complex seizures. And how you are going to treat? So the first and foremost treatment, you have to give the diazepam or the lorazepam. Followed, if it is not controlled, then we can go for the phenytoin. Then we can go for the valproate. Right? This is how we are going to see the pattern for the febrile seizures. Okay? And other treatment, you have to treat the underlying cause. That means fever. So you have to give the PCM for the baby. Next, first seizure is done, and second one is the absence seizure. Second one is the absence seizure. And absence seizure is not seen with any fever. Okay, so there is no fever in this babies. Especially this is seen as an episodic. Okay, episodic and recurrent. Sometimes hyperventilation can trigger. And age group is 5 to 12 years of the age, especially in the school complaints. There you are going to see. And drug of the choice for this patient is a valproate as per the India guidelines. If they ask the other guidelines, then you have to choose the ethosuximide. Okay, ethosuximide. Next, third one. Third syndrome is the myoclonic type. On the EEG, you are going to see the high spikes 5 to 10 hertz. 5 to 10 hertz is seen. And this drug of the choice for this patient is the valproate. Next, we also have the Zanz syndrome. Zanz syndrome is also type of the myoclonic only, myoclonic subtype. And again, treatment of the choice is same, valproate. Next, fourth one, that is the West syndrome. also known as your salam spells. And for this, we are going to give the ACTH. But this West syndrome with the tuberous sclerosis, then we have to give the Vega battery. Vega battery. Next, fifth one, that is the Dravet syndrome. And for this patient also, we are going to give the valproate. Sixth, Lennox-Gastaut. And here also we are going to give the valproate. And other type of the myoclonic, such as measles type. Measles final complication, like chronic complication, if this measles, they are going to present with a myoclonic only. So actually carbamazepine we don't give in the myoclonics, but if it is associated with the measles, here the drug of the choice is carbamazepine. Carbamazepine can be given, but these patients we are not going to give, only with the measles complication, then we have to give the carbamazepine. Next, see one by one pictures. Okay, so what you are seeing here, guys, purpura and ecchymosis. Ecchymosis. This is a type of the rash that we are seeing here, and this patient is suffering from the fever and nuchal rigidity. So now identify what is this condition. And I have done the CSF analysis for this baby, and CSF is showing the multiple neutrophils and high protein, and severe glucose is decreased. So this is meningitis. And what could be the cause with the severe rash? The severe rash is due to meningococcemia. Meningococcemia organism. Okay, this is causing the meningitis. Okay, mostly aerosol patients. Next, another purpura. Another purpura. Another purpura, and this is non, we can say this is a palpable. You can feel this is non-palpable, guys. This is non-palpable, whereas this one is the palpable type. And the patient is having the abdominal pain. Patient is having the urinary like hematuria, and platelets is normal. Platelets is normal. Joint pains is also seen. So this condition is Henold's clinic purpura. That means small vessel and IgA vasculitis. And what is the treatment for this patient? Steroids. If there is a severe abdominal pain, we have to do the surgery. Next, moving on to this is the hyperplasia, right? Congenital adrenal hyperplasia. Okay, so this patient is having the different types of the defects. Autosomal recessive condition. They're having the defect in the 21 hydroxylase, 11 beta hydroxylase, and 17 alpha hydroxylase enzymes that are the defect. And what is the most common? The most common is 21 hydroxylase. We have to differentiate between the BP and the testosterone or androgens. So just remember like this: 2, 1, 1, 1, 1, 7. So whichever is the high number, that will be decreased. So BP is decreased in the 21, and here 1 is having increased. All the ones will be increased and all the other numbers will be decreased. Okay, so testosterone is decreased only in the 17 alpha. 21 hydroxylase is only having the BP less, remaining all will be increased. That's how you can remember with the small mnemonic. Okay, because with the with the both the classification and all that hormonals will be very hard to remember. Just remember with the mnemonic, you can easily answer. So this baby is having the distinction. This baby is having the macroglossia, macroglossia, and hair is coarse hair, coarse hair, and hernia, umbilical hernia. What is this condition? So this condition is known as a congenital hypothyroidism. Congenital hypothyroidism. This is also recent INCT and last NEET PG question. So congenital hypothyroidism, what is the most common causes, guys? The most common cause is the dysgenesis. Most common cause is the dysgenesis. Can this land this patient in the growth retardation? Can this land? Yes, this can cause the growth retardation is seen in this patients. And all the other features, as I said, distension, microglossia, hernia, and coarse hair, and mental retardation is seen. Is it the mental retardation is seen? Yes, mental retardation is also seen with this patient because basal metabolic rate is suppressed. So that is why the patient can also have this condition. Treatment is hypothyroidism. So you have to give the thyroid drugs that has to be given for this baby. So these are the some of the important topics, guys. I have covered almost all the important topics. You just have to revise and revise again and do the practice of the MCQs. Okay, so please do watch other subjects also. All the other subjects is also very important. If you want to avail the notes, please do text me in the Telegram group. And until then, happy preparation, guys. Don't forget to subscribe, share with your friends, and also please do like the video so that it can reach the many students and they will also get the benefit from this fruitful discussions. Okay, until then, happy preparation. See you in the next subject. Bye, guys.